Morning, everybody. For those of you who thought I was going to speak on a different subject, I am the second speaker of the morning, so you haven't come to the wrong room. So I'd again like to thank the organizers, Manoj and Banshee, for inviting me to take part in this great symposium, and thank you for the kind introduction. Title of my talk is Hypoglycemia, Best Way to Measure It and Impaired Awareness of Hypoglycemia. These are my disclosures. And I just want to start by reminding you that within 2 years of the discovery of insulin, Banting published a paper in the British Medical Journal, which was prophetic. And he said, as a result of insulin, as a side effect, hypoglycemic reactions, it is felt that hypoglycemia constitutes a real source of danger. And he was correct. And to this day, over 100 years since insulin was discovered, insulin arguably, as a side effect, hypoglycemia is the biggest worry for many of those who have to use insulin. I'm going to talk about how we measure hypoglycemia, and it's changing. And with referral to the previous session, AI is already being incorporated into avoiding hypoglycemia. How do we measure impaired awareness? Evidence concerning the impact of hybrid closed loop and technology on impaired awareness, and are other interventions more successful? So in 2017, I had the honor to chair the International Hypoglycemia Study Group, who pointed out the deficiency at the time of the definitions of hypoglycemia, and we persuaded the EASD and American Diabetes Association to reclassify. And this classification stands to this day, although I do think it's in need of updating. Level 1, hypoglycemia alert, glucose less than 70, and no symptoms necessarily, and alerting those with diabetes to whether they should take action. Level 2, which was the new level, serious and clinically important, because at that glucose level, it caused adverse consequences, which of course I'll mention. Glucose less than 54, equivalent to 3 millimoles per liter. And then level 3 was the same, severe hypoglycemia, but we added the term impaired cognitive function sufficient to require external help, and that allowed pediatricians to use the same definition, and ISPAD went along with that. And since then, many organizations, including FDA and EMA, the European regulatory agency, have adopted, although some countries have still to move to this classification. And then, of course, we now have CGM, and I was involved with a paper published in Diabetes Care in 2019, which was a consensus. And we had good reason for 4 to 10 millimoles per liter, 70 to 180. But frankly, and I acknowledge that, although I was a co-author, when it came to hypoglycemia recommendations, we used what's not terribly reliable, and I was one of the experts, expert consensus. We came up with less than 5% being the maximum, 4% down to 53, and then 1% less than that. And we said, well, people should remain generally with less than that, but up to that, it was okay. And probably it's not okay. And we need to change this consensus. You can see for high-risk older people, it was less than that. But otherwise, it remained. And the limitations are shown in the consensus statement recently published on clinical trials. And it points out that CGM is reliable for time in range, but what constitutes a clinically relevant change between comparative time points in any other metric is not standardized, and there is no consensus for clinically important changes in metrics other than time in range, and that absolutely includes hypoglycemia. And evidence that we have collected and published in another study recently, in a big pan-European study called HypoResolve, we looked at hypometrics using a wearable app, in which those in the study could signal when they recognized hypoglycemia, and because they were using CGM, the sensor was detecting all episodes of hypoglycemia less than 70 milligrams per deciliter. The patients with the app would report their experience of hypoglycemia, which of course was different, and there were some where it was matched, sensor detected and person reported hypoglycemia. Now, if hypoglycemia is so bad, then sensor detected hypoglycemia should be causing adverse effects. And you can see all these PROs, which we then asked the individuals participating in the study to fill in. We measured what impact they had on their everyday lives. You can see sleep quality, energy, negative effect, productivity, fear of hyper and hypoglycemia, and social functioning. And note that with the sensor detected hypoglycemia, there was very little effect. If you look, however, at the person reported hypoglycemia, the episodes in pale pink at the bottom, you can see a huge impact of many of those episodes. And what this shows is that episodes of hypoglycemia, particularly those that disrupt a person's everyday action, forces them, of course, to take action. For example, in the middle of the night, waking to take oral carbs, then this has a much bigger impact than the episodes which the sensor are detecting. And this suggests, to me at least, that CGM has limitations, major limitations, and this percentage that we said people should avoid is based, frankly, on little evidence. So the message is, sensor-detected hypoglycemia does not affect outcomes, but patient-reported hypoglycemia absolutely has an effect. Let's look at the other limitations of CGM-detected hypoglycemia. Increasing 1% in time below range, below 70, has a minimal effect in increasing severe hypoglycemic risk. But the number of events, even those which are not severe, is a much stronger predictor of important outcomes shown on the right. What we did here was to look at a combination of clinical trials from the 3 major insulin manufacturers, and then we followed what happened to those individuals just for 6 to 8 weeks later, and what we showed is that the more events that somebody was experiencing in these clinical trials had significant effects on consequent important clinical outcomes, including, for example, severe hypoglycemia. So non-severe events were predicting severe episodes. They were predicting overall death, cardiovascular death, and major adverse cardiac events, showing again that it's the number of events which occur and their frequency which seem to be far more relevant, frankly, than percentage below range. So in summary, in terms of measuring hypoglycemia, CGM offers a usual broad metric of hypoglycemic risk, but the choice of less than 5% as a safe target by so-called experts, which I consider myself one, note the inverted commas, was arbitrary and lacks convincing supportive evidence. The number and glycemic level of episodes remains relevant and important as a predictor, but CGM technology will facilitate rapid and automatic collection of frequency and duration and depth of hypoglycemic episodes, so it's clearly highly important, but in a different way. Let's turn to impaired awareness. There are 3 questionnaires that we use clinically, Clark, Gold, and HypoAQ. They all ask slightly different questions, from just saying, how often do you recognize hypoglycemia, to the HypoAQ, which is 33 items, not the kind of thing that you do in your everyday consultation. But essentially what they're doing is identifying people who can't recognize hypoglycemia as well as they used to. The threshold for both Clark and Cold, by coincidence, is at 4 or above. That's the score. And for those of you who say, I haven't got time even to do that, all you should do is say to the person sitting in front of you, what's the kind of glucose level at which you recognize that you are low? And if they say it's above 55, then that's good. They have adequate warning. But if they're not recognizing until they get to under 55, that is a warning, and you should be aware of that, because that takes approximately 20 seconds to ask and answer, and will help you to identify which individuals have impaired awareness of hypoglycemia. Importantly, of course, this is not the gold standard. It's quick, and you do it in the clinic. And what we really need to do, but of course we can't, is to lower the glucose in the lab and measure the counter-regulatory changes and the cognitive function, which of course we do experimentally. But importantly, there's a reasonable correlation between the measure of awareness and those symptoms during experimental hypoglycemia, although it's not so good at predicting increases in epinephrine, adrenaline, which of course is crucial to protecting people against hypoglycemia. What happens during duration of disease? And we now know that awareness of hypoglycemia decreases the longer you have type 1 diabetes, and it's really very common. Prevalence is probably between 20 and 25%. That's 1 in 4 of the individuals with type 1 diabetes that you see. It's commonly more common in older people, people who've had longer diabetes duration, and importantly, it predicts the likelihood you have severe events. And this nice study by Baron-Freer and colleagues shows how the risk increases the longer you've had diabetes. But what is the cause? And for many years, people couldn't understand why people lost their warnings of hypoglycemia. Originally, the hypothesis was they ran their sugars too high. But what was discovered actually was the complete opposite. People who had tight control in those studies back in the 70s and 80s actually had more episodes. So when I was working in St. Louis in the early 90s, we tested a different hypothesis. And it was based on the observation that controls, non-diabetic individuals, said to us, when I first have a test as a control, I feel really terrible, but by the second or third, I hardly notice hypoglycemia at all. So we therefore tested that hypothesis that the main cause was an episode of hypoglycemia. We took medical students without diabetes and we lowered their glucose to around 45 milligrams per deciliter, and we measured their increase in epinephrine, shown in green, and we measured a symptom score, and we got people to score how much sweating they had, how much they were shaking, whether they could feel their heart beating. And you can see that was a normal response on day one. In the afternoon, we lowered their glucose to around 50, 55 for 2 hours, and then we brought them back in the next day to see what had happened. And you can see that at the same glucose, 45 milligrams per deciliter or so, we'd halved their adrenaline response and we'd halved or reduced their symptom response. So we showed that episodes of hypoglycemia can reduce protection against further episodes. And that has been repeated in people with type 1 and type 2 diabetes. We also hypothesized in our paper that if you could prevent hypoglycemia, then you could restore perhaps those symptoms. And so this is a nice study done by my friend and colleague Stephanie Amell in London as a result of our original paper. They took 12 people with impaired awareness and they managed to stop them having any hypoglycemia for 3 weeks. I should emphasize that took quite a long time. Some people took 3 months to avoid all their hypoglycemia. This is the before, and you can see that they're experiencing symptoms at around 40 milligrams per deciliter. But you'll note, if you look at the cognitive function, that their brain function is becoming impaired at around 55 milligrams per deciliter. This explains why they have impaired awareness, because by the time they get symptoms, they don't recognize that they're low because their brain isn't working. But if you avoid all hypoglycemia, you can push that threshold for the onset of symptoms back above that for cognitive function, which doesn't change, and explains why somebody can restore awareness. So you might say, problem solved, all we have to do is to prevent hypoglycemia. But as you'll all be aware, particularly in type 1 diabetes, that is not easy. And so impaired awareness of hypoglycemia remains a problem to this day. It affects a quarter of people with type 1, probably up to about 1 in 10 people of insulin-treated type 2. It's inducible by exposure to hypoglycemia, as I've demonstrated. It's reversible, at least it was in the 1990s, by avoiding exposure to less than 55 milligrams per deciliter. But most important of all, it increased the risk of severe episodes, both in type 1 by around 6-fold. But look at about type 2 diabetes. People with type 2 diabetes, 1 in 10 on insulin, have a huge risk of severe episodes if they have impaired awareness of hypoglycemia. So those of you who see people with diabetes, for goodness sake, ask them one quick sentence in every consultation: at what glucose level do you feel hypoglycemic symptoms? I think you'll be surprised at the result. So you might say, we've been hearing the great advances in technology and AI, which are solving all the problems of diabetes. I don't think so. Let's look at that CGM. Of course, it's important in those with type 1 diabetes and impaired awareness. This was the study which compared CGM to standard glucose monitoring. It's one of a number of studies which have been done. It was a crossover study, and you can see that CGM was better at identifying hypoglycemia. Not a surprise. Not only that, but it reduced severe episodes. So job done? Not really. If we look at this, although there was less hypoglycemia, there was no change in awareness of hypoglycemia awareness. So CGM on its own doesn't work. Let's look at hybrid closed loop, and this is an early study. It's not really hybrid closed loop. It's low glucose insulin suspend, 6-month trial, 153 participants, long duration, but they did well to reduce the number of severe events and overall hypoglycemia. Again, no significant change in awareness. So there was a contradiction here. Those early experimental studies seemed to show you could improve awareness, but these big studies involving large numbers were much more disappointing. And the possibility that actually what you need is a very focused study was suggested by this study from Mike Rickles' unit back in just a couple of years ago. They took a small number of individuals, just 10. They really worked hard with them. And you can see that the Clark score, above 4, denoting impaired awareness, actually improved during 18 months. And their hormones, particularly epinephrine, was restored to a degree, but 50% still remained unaware as defined by the Clark score. And if we look at AID systems on impaired awareness, randomized controlled trials, this is randomized controlled trials. You note a little bit of a shift, but not significant. And if we look at observational studies, you'll also see that there's an improvement. And the authors of this paper in 2024 said, we don't think this is good enough. Let's compare it with real-world data. This is the T1D exchange, the best centers in the US. And you can see that 50% are using hybrid closed loop. the number with impaired awareness exactly the same as those using blood glucose monitoring. So in large numbers, it doesn't work. But if we compare psychoeducational interventions, a factorial study where we compared CSI, MDI, blood glucose monitoring with impaired awareness, and we trained the patients to be aware of their symptoms, you can see that their hypoglycemia went down over the 24 weeks of the study. Severe episodes nearly disappeared, and all it was a brief educational intervention right at the beginning. Look at the number of people who recovered their awareness. With a psychoeducational intervention, it was over 70%, much more effective than technology alone. So to finish, what are the questions and what are the answers here? If all hypoglycemia could be prevented, can we reverse impaired awareness? Well, maybe. Perhaps we need to go longer and better. We need perhaps to wait for cell therapy as a cure. Psychoeducational interventions may help people recognize symptoms and result in people taking action earlier. Is all impaired awareness caused by repeated hypoglycemia? I think not. Cerebral damage from repeated episodes may prevent reversal, so we need to define the phenotype and conduct clinical trials, one of which is now starting actually next month, testing 300 individuals, and I'm honored to be involved in a trial which we think will answer those questions, comparing psychoeducation to closed loop and in combination. So in conclusion, a more complete understanding of impaired awareness may identify more effective clinical pathways. Technologies are providing useful measuring and reducing rates, but they're not a cure. Thank you for your attention.